Hello and welcome everyone. Today we will do a literature review on the restriction of intravenous fluid in ICU patients with septic shock, the classic trial group study. It was published in 2022. Septic shock is a major cause of death globally, prompting the need for enhanced treatment approaches. The Surviving Sepsis campaign recommends an initial fluid administration of 30 ml per kg of body weight despite very low quality of evidence supporting it. Post-initiation resuscitation, there is no specific guideline on using restrictive versus liberal fluid strategy due to insufficient evidence. Observational studies and RCTs link higher intravenous fluid volumes in sepsis and septic shock patients to potential harm, including increased kidney injury, respiratory failure, and mortality. A review comparing lower versus high fluid volume in septic patients found both the quantity and the quality of evidence to be very low. This study was conducted to investigate the impact of restricting intravenous fluids on mortality and other critical outcomes in ICU patients who have septic shock. So coming to the trial design and the oversight. This is an international stratified parallel group open label RCT. It was conducted from November 2018 to November 2021 across 31 ICUs in 8 countries. The written consent was taken from patients and their legal surrogates. It is funded by the Nordic Foundation, which did not influence the trial design, conduct, or reporting. The trial protocol and statistical analysis plan was published and is available. An oversight committee of the Collaboration for Research in Copenhagen and an independent safety monitoring committee was looking after the study. Interim analysis was done at 10% and 30% and safety assessment at 50% of enrollment. Data monitoring ensured external site monitors and central staff. Trial integrity is vouched by the authors, who also wrote drafts and decided on publications. Coming to the study population, the inclusion criteria were the age, which was calculated in whole years at the time of randomization of the date of birth. Only patients in ICU who were planned to be in ICU were eligible. Age had to be more than 18. Septic shock definition was based on the sepsis 3 criteria, that is suspected or confirmed infection or a positive blood culture, who required vasopressor to maintain a mean of more than 65, or a plasma lactate with a sample of at least 3 hours. Fluid intake received at least 1 liter of IV fluids in the 24 hours prior to the screening. Exclusion criteria: more than 12 hours of septic shock by sepsis 3 criteria at the time of screening, needing transfusion of blood products, acute burn injuries, pregnancy, consent issues. Additional criteria were there in Italy, which is allergy to the study solution, recent less than 3 hours of ventricular fibrillation, sarcoidosis, untreated Addison's disease, known hereditary thrombophilic disorders. Randomization. Now, it utilized a centralized computer-generated allocation sequencing based on the trial site and presence or absence of metastatic or hematological cancers. The patients were randomized assigned to 1:1 ratio. It was done in a permitted blocks of 6 or 8. Patients were allocated to either restrictive or standard intravenous group. Patient, clinician, and investigator were not masked to the treatment group assignment. The data and safety monitoring committee, trial statisticians, and members of the managing committee were blinded during the initial drafting of the abstract. Trial interventions. Restrictive group. IV fluid were not given unless under specific circumstances outlined by the classic criteria. The criteria were severe hypoperfusion or circulatory impairment with a lactate of more than 4, mean arterial blood pressure less than 50, mottling beyond the kneecap with a score of more than 2, urine output less than 0.1 ml per kg per hour for 2 hours post randomization. A bolus of 250 to 500 ml of intravenous crystalloid solution was administered, followed by re-evaluation. Overt fluid losses, that is vomiting, diarrhea, and bleeding. IV replacement should match the volume lost and should not exceed it. Failed oral or enteral route. To correct dehydration or electrical imbalances. To ensure total intake is 1 liter per 24 hours. IV fluid may also be used as carrier for medications, minimizing the volume as much as possible. No restriction on oral or enteral intake. Coming to the standard group, no upper limit on the use of intravenous or oral fluids. Criteria for IV administration: administer IV fluid in case of hypoperfusion, circulatory impairment, continuing as long as hemodynamic variables improve. Follow-up: replace fluids for expected or observed losses, dehydration or electrolyte imbalance in accordance to the surviving sepsis guidelines. Now, what were the outcomes and the definitions? The primary outcome was 90-day mortality from the time of randomization, and secondary outcomes were serious adverse effects observed in the ICU, that is ischemic events, cerebral ischemia, acute myocardial infarction, intestinal ischemia, limb ischemia, severe acute kidney injury, at least a threefold increase in the basal serum creatinine or serum creatinine more than 4, or initiation of RRT. Serious adverse reactions like generalized tonic-clonic seizures, anaphylactic reactions, central pontine myelinolysis, severe hypernatremia, severe hyperchloremia, severe metabolic alkalosis, days alive without life support at day 90, that is calculated based on non-use of vasopressor or inotropes, mechanical ventilation or RRT within 90 days, days alive and out of hospital at 90 based on discharge from initial hospitalization, subtracting any days of rehospitalization, and up to the day of death up to 90 days. Secondary outcome not reported in this publication are first year mortality, which could be of any cause, health related quality of life outcomes assessed by EQ5D5L and EQ-VAS, cognitive function, which was assessed by Montreal Cognitive Assessment mini test score. There were some subgroups, and these are the definition of those subgroups. Respiratory support based on the use of invasive or non-invasive ventilation, which is mask continuous CPAP or CPAP by tracheostomy, excluding intermittent CPAP and high flow nasal oxygen therapy. Severe acute kidney injury defined by modified KDIGO scoring, stage 2, stage 3. And the other classification was severe metabolic failure, which was defined by plasma lactate of greater than 4, patient weight defined by body weight at the time of randomization, which was measured or estimated, intravenous fluid prior to the administration, that is IV fluids received within the last 24 hours before randomized, regardless of the location, that is pre-hospital or in-hospital, crystalloid of type, that is saline, bicarbs, Ringer's lactate or plasma light, colloids, albumin, gelatin, hydroxyethyl starch, dextran, and blood products, RBC, plasma and platelets. Intraosseous fluid was also counted as IV fluids. Trial criteria for discontinuation and withdrawal. The consent withdrawal, that is patient or surrogate could withdraw consent at any time. Procedure for withdrawal was follow national regulations. If consent for continued data registration was given, daily data and follow-up were still collected. Previous collected data was used if permitted by patient or surrogate. Discontinuation or withdrawal of the investigator. Reason for withdrawal to be noted: inappropriate fluid protocol could be one of the reasons. Withdrawal from active therapy, serious adverse effects, and lastly involuntary hospitalization. Data handling. In consent for data collection wasn't withdrawn, data was collected and follow-up was continued. Patient remained part of the intention to treat analysis regardless of the trial intervention continuing or not. Handling of the patient transfer. Transfer between ICUs. If a patient was transferred from one ICU to the other and is a part of classic trial, they continued to be the participant of the trial. If they were transferred to a non-classic ICU, then they were considered discharged from the ICU. Follow-up. All transfer patients were still followed up for primary outcome, secondary outcome, alive at day 90. Statistical analysis. First, the sample size calculation. The requirement was 1,554 patients to achieve a power of 80. This was to detect a 7 percentage point difference in 90-day mortality corresponding to a 15% relative risk of change, based on an expected 90-day mortality of 45%. Now, analysis approach. The primary analysis was performed on an intention to treat population, excluding 5 patients who withdrew consent for the data usage. Utilized binary logistic regression, adjust for the stratified variables, trial site, which is presence or absence of hematological and malignant cancers. Relative risk and 95% confidence interval calculated using G computation due to non-convergence of the other models. Adjustments made for stratification variables. The simplified mortality score for ICU, focus of infection, and use of systemic glucocorticoids. Further analysis included per protocol population and predefined subgroups as we have already defined. Regarding this SMS scoring for ICU, I will show the score at the end. Secondary analysis, all dichotomous outcomes analyzed using logistic regression adjusted for stratification variable, unadjusted Fisher's exact test performed by binary outcomes, days alive without life support and days alive out of hospital at 90 days, and analyzed using Van Eltron test adjusted only for site due to non-suitability of other distribution assumptions. Data integrity and statistical significance. Missing data, no imputation was performed as missing data was less than 5% of all outcomes. Significance levels. Two-sided p-value of less than 0.05 was considered significant for primary outcome. A p-value of less than 0.01 was required for statistical significance in subgroup secondary outcome analysis due to multiple testing considerations. The software they used was SAS and R software. Handling of the missing data. Missing data was 15 in the restrictive group and 8 in the standard group had no baseline data. Now this data, primary outcome were missing in 9 patients, 5 had all data removed except for group assignment due to the withdrawal of the consent, and secondary outcome data was missing in 36% of the patient, and these patients were considered discharged from ICU after the consent was withdrawn. No imputation was performed for missing data at the threshold of imputation was not met, that is the cutoff was 5%. So special considerations. One patient was assumed alive at day 90 after migration from Switzerland on day 76 and became unreachable. A total of 110 patients were transferred to non-trial ICUs within 90 days. Data on the use of life support on these patients was captured via electronic records and contact with non-trial ICU staff. So coming to the results. This was the screening and randomization. 2,223 patients were assessed for eligibility, 667 were excluded, mainly because mostly were septic shock for more than 12 hours and 235 for no provision for consent. So they included 1,554, 770 in the restrictive, 784 in the standard. In the restrictive, you can see here 12 patients, 6 patients, 3 withdrew consent, 3 were lost to follow-up, so 764 were included in the primary analysis. In the 784 in the standard group, 3 were excluded, 2 for withdrawing consent, 1 was lost to follow-up. So 781 were included in the primary analysis. Regarding the baseline classification, the age, sex were similar, the coexisting conditions were similar, median time to ICU to randomization was 3 hours, and median predicted 90-day mortality was 40% in both the groups. Source of ICU admission was mainly emergency and hospital wards, and focus of infection was GI and pulmonary. The other parameters are essentially comparable. The highest dose of NORAD was 0.25 microgram per kg per minute. Regarding the cumulative fluid balance between the two groups, this is the cumulative fluid balance at day 1, which was 500 in the restrictive, and in the standard it was 1,313. So there is a significant difference. At day 5, they had a similar difference between the two groups, 1,450 to 3,000. Day 90, it was 2 liters. Now this was the intravenous fluid. Total fluid volume, including the oral, was also similar in the two groups. Cumulative fluid balance was also less in the restrictive group. So they could get some kind of a difference between the two groups, though the clinical significance of this could be debated because the difference is only around 500 to 800 ml. So based on this, the primary outcome that they were looking for, that was the mortality, which was similar in the both groups. So there was no difference. In the severe adverse effects also were not different, neither in terms of the ischemia nor the acute kidney injury. And other serious adverse effects were also similar in the two groups. Regarding days alive without ventilator support, which was similar, days alive outside of the hospital was also similar between the two groups. So this is the overall survival, which shows it is essentially similar between the two groups. The subgroup analysis also shows no much difference. In the respiratory support, if it was present, then it favored restrictive strategy. AKI is again similar. Plasma lactate more than 4 or less than 4, it is hardly is mattering. And body weight, again, very similar. IV fluids at randomization more than 30, then it favored restrictive, and if it was less than 30, and then it was more in favor of standard. But there was no clear difference statistically between the two groups. There were a lot of protocol violations. The number of one or more protocol violations in the restricted group was 21%, which is very high, and in the standard group was 13%. Number of days with violation among the patients with protocol is 1 day. Percentage of days with violation among those with violation was almost 20 days. So the percentage is very high. IV fluid volume with violation is around 100 ml. So there were a lot of violations which could make the interpretation very difficult. Regarding serious adverse effects, there were no major serious adverse effects seen between the two groups, whether it is anaphylactic reaction, pontine myelinolysis, or other electrolyte imbalances. So what are the strength of this trial? This trial is a very robust study with a very good design, which included international centers. It achieved 99.4% follow-up rate, which is very good, and the data is very complete. The design is RCT, which is the gold standard. The pre-testing was done. They've conducted a pilot trial to test parts of the protocol beforehand, which ensured that it was feasible and practical. The approach helps in balancing out a lot of confounders, which they did very nicely, especially the cancers between the intervention groups, which is crucial to attribute effect specifically to the intervention tested. Now, it also has its limitation. Clearly, it was very difficult to blind, so it will have its effect. There will be some kind of a bias here. Incomplete data on co-interventions. We are not very sure what the co-interventions, like, which could have affected the hemodynamics and how they were done. That is the vasopressor usage and the diuretic usage. A significant number of protocol violations is reported, as you have already seen. It is very, very high, which makes the internal validity compromising. And the initial fluid administration was not very clear cut. Patient received some fluid which might affect the outcomes. So the trial may not have adequate power to detect difference in mortality in certain subgroups and secondary outcomes. Now, what are the recommendations for the future trial? Try to make blinding up if possible, expand the data collection to more co-interventions, strict protocol adherence, trying to overcome the limitations that we faced this time. Pre-enrollment fluid management must be standardized and documented, increase sample size of the subgroups, and use more sensitive outcomes like besides mortality, that is including more outcomes which are specific for the fluid, like quality of life or vasopressor duration or functional outcomes. Now, based on this study, the conclusion is that among adults with septic shock in ICU, intravenous restriction did not result in fewer deaths at 90 days than standard intravenous fluid therapy. So overall, if we think about this, this may not be a practice changing study because the overall impact or the difference between the two groups was only of 500 to 800 ml per day. So it is questionable whether that amount of fluid could have resulted in significant outcome differences. So we need more standardization of the pre-administration, the co-interventions, and the outcomes that we are trying to measure. It is very difficult to attribute mortality at 90 days to fluid that was given in the initial 2-3 days. So we need to find more better outcomes over here. And this is the SMS ICU which they were using for their mortality predictions. Thank you for your patience.